Hi, my name is Dr. Ashkan Lashkari. I'm MOASC president. Today, I'll be talking about CAR T cell therapy with my colleague, bone marrow transplant and CAR T cell specialist Joshua Mansour from Kaiser Sunset City of Hope. And he and I will be discussing the increased role of CAR T cell therapy in hematological malignancies. And now we're seeing this trickle into other spaces as well. Dr. Mansour, thank you so much for joining us.
Yeah, happy to be here. Thanks for putting this on. This is great.
Absolutely. I think the hope here is that we wanted to address the role of CAR T cell therapy as it stands today. This is increasingly being used in earlier lines of hematological malignancies, and we're now seeing clinical trials in solid tumors. And so, really harvesting cell therapy in the role of cancer treatment has really revolutionized how we're taking care of patients. And what we want to do is try to see how this treatment can be utilized more effectively by community cancer specialists. As you know, most patients are treated, cancer patients are treated in the community. And CAR T cell therapy is largely provided at academic facilities that have the bandwidth to provide such treatment. And so, of course, we wanted to get your expertise in helping us kind of bridge some of the challenges that are inherently associated with getting patients to CAR T cell therapy, identifying um, who is a candidate, when to refer, and what other challenges are at play there. So perhaps we can jump right in and go from there.
Yeah, I think you bring up a lot of great points. So I'll briefly go through CAR T cell therapy and what it is. I won't spend too much time on that because, as you alluded to, there are a lot of other things that I think are really important that we discuss, such as some of the barriers to referral, the timing of referral, how to work best between the cell therapy specialists as well as the community oncologist. So spend just a few minutes though touching upon some things that I think are important, and maybe some of the community oncologists can discuss with their patients prior to the referral. So, what is it? CAR T cell therapy. So, again, it's immunotherapy that helps T cells recognize the cancer cells in the body and attack them. What's the process? So, T cells are extracted from the body through a pheresis process. The chimeric antigen receptor is attached. These T cells, genetically engineered in the lab, are then reinfused into the body. That reinfusion process only takes about 10 minutes, usually done as an outpatient. And at that point, the CAR T cell is able to recognize and attack a cancer antigen and then start the process. So here's a basic comparison of a normal T cell as well as a CAR T cell. So as you can see, you have the T cell, the signaling domain, then the antigen recognition domain. So that's the CAR right there. And that will then go and target the tumor cell. So this is an illustration about the process kind of that I just discussed to be able to help people visualize this, right? So in the beginning, you have removal of it, and this typically occurs in the outpatient at a pheresis center. The pheresis center could be at an academic center or at a third party if that place doesn't have a pheresis center, or if there are logistical issues with timing for that. A vein check is done to determine if they're able to access it there, whether they need a line. It's then quickly pheresed out, so the T cells are extracted, then sent where the CAR, the chimeric antigen receptor, is then attached to these T cells. That's when the manipulation occurs. They're then growth, so millions of these CAR T cells. They're then sent back up to that center and then reinfused. So as you can see right there, you have that little bag. It's really about the size of a palm of your hand almost. Takes only about 10 minutes. And again, we're moving really to doing this outpatient instead of inpatient. They'll start outpatient as a process. And then once the patient has potentially some of the adverse effects, the patients will then be taken to the hospital or admitted as an inpatient to help with that.
Dr. Mansour, perhaps we
Yeah,
can go back to the last slide, and I just wanted to
sure.
ask a quick question that I think a lot of doctors and including myself are wondering, and that is, what percentage of patients who are referred for CAR T cell, collection and development actually are able to subsequently have those CAR T cells grown to the point where it can be reinfused back into them. Another question is, how much is there perhaps too much treatment that a patient may receive prior to CAR T cell therapy that might uh, make it more difficult for them to have these cells grown and subsequently reinfused?
Yeah, those are two very good questions. So typically greater than 90%, I'd say even greater than 95% of patients will collect well. The cells will be in spec and they'll be able to be reinfused. There are, of course, as you mentioned, a subset segment of patients where, depending on the types of treatments or how many treatments that they have received over time, makes it a little bit more difficult to collect. And then the CAR T cells may fall out of spec. And then there's another subsegment of patients where, well, we collect them, but unfortunately the disease has progressed very quickly, and those patients then do not receive the CAR T cells. And then there's another one, and that's where the patients will collect the CAR T cells, have bridging therapy, actually go into a CR, and then we'll wait to either infuse them at a later time when the disease relapses or recurs, or we will then get rid of the CAR T cells and they will not be used because the patient maintains a durable CR. So
Perhaps I can just ask a follow-up question. Is there a shelf
yeah,
life to these? Is there a shelf life to these CAR T cells in terms of how
yeah,
long it can be stored?
good question. About a year.
Okay. So if they're not used within a year, then effectively they would have to repeat the process if
Exactly.
that treatment were to be done. Okay. Go ahead. Let's continue. That sounds great. Thank you.
So what we really think also around that is patient eligibility, right? We want to know what patients, or from the community side, physicians want to know, well, what patients can be eligible for it. So the blood counts need to be stable enough for leukapheresis, right? So um, adequate WBC count, hemoglobin, and platelets. Those are all different depending on the product. Relative disease stability, right? Because depending on the product itself, it could be weeks. However, with some of them, it could be months. So depending on the disease as well as the product, that is important to consider. Can the patient tolerate bridging therapy in between, or does the patient even need bridging therapy? And again, the ability to tolerate some of these toxicities that I'll briefly go into. So if they need to have stable organ function, neurological status because of the risk of ICANS. And then a question that I commonly get is age. Is there a cap for age? Well, there's no cap for age, but again, we need to determine, is their performance status at that age adequate to be able to withstand some of the adverse effects that they may have.
Dr. Mansour, we're going to get to some of the barriers to referral, but perhaps we could touch base on some of the barriers that you just mentioned now, and that is, assessing patient eligibility. Who should be assessing patient eligibility? Should it be the doctors in the community thinking about referring, or should they, if they feel that patient is a potential candidate based on the fact that a CAR T cell therapy is an option in the relapsed setting, for example, should they just refer at that time with the idea that the sooner they get them to a cell therapy department, wherever that is, and have the CAR T cell specialist that at that point make the determination?
Absolutely. I completely agree with what you've said. So I think when it comes to that age and performance status, well, if you'd be worried about giving them an aggressive therapy, I think this may not be an option. This is very well tolerated, even in older patients. But again, if their performance status at that time makes you question a few things, that might not be the best candidate. But if they're an older patient, they're doing well, you're not concerned about giving them additional therapy and think they can tolerate it. I think it's better to refer and let the specialist then make that decision.
Yeah, I mean that's been my experience as well because I know that there are multiple CAR T cell therapies, some of which are there's several that have been approved in the same line of intervention. For example, relapsed diffuse large B cell lymphoma. There's more than
Mm-hmm.
one product that's available, and from my understanding and from what we've learned in the literature is that there's some products that may be better tolerated than others, in which case, patients for whom, whether they may be older or um, their comorbidities may not be as, may be higher, still they may be candidates for certain products, perhaps more than others.
Absolutely. Absolutely.
Okay, well, so it sounds like then the bottom line is, if you're thinking that the patient is a candidate, even though if you may not be sure, or even if you're concerned a little bit, refer them early, have a discussion with a CAR T cell specialist, and kind of go from there and make a shared decision.
Yeah, I think that communication, that early referral and that communication between both parties, because again, a lot of times, even as the so-called specialists, right, we really rely on the information from our colleagues out in the community who are seeing those patients, because those have been the doctors who have been seeing those patients more frequently and can really give you a better idea of their performance status as well and how they may be able to tolerate the therapy.
Yeah, I think that's a great point.
So some of those acute toxicities that, again, this really occurs at the center where they're being treated, but I think it's still important for someone out in the community as well to understand is they can get cytokine release syndrome, neurotoxicity, infection, this robust inflammatory responses because of the CAR T cells, and as well as more rare, but even HLH. And so we all know how severe that can be. So this gives you an idea of why we are concerned with organ function, performance status, age, things like that. Um, then post CAR T cell management, why do I think it's important to briefly touch upon this? It's because this is where a lot of patients will be hopefully back to their community oncologist being seen, and something for the community oncologist to also really take a look at it and pay attention to look for these signs that may be actually an adverse effect from the CAR T cell therapy. All this can be celloplasia. We frequently try and work with our colleagues out in the community for potentially if they need additional Neupogen, red blood cell transfusions, platelet transfusions. We don't want them to have to drive all the way to where they were being treated just to receive that if we can coordinate that locally. Signs of infection. So they're more susceptible to infection. So having the right prophylactic antivirals, antifungals, antibacterial medications, also looking for those signs because they will be more susceptible. Hypoglobulinemia, receiving IVIG infusions if they need it to help with that. And then some signs of delayed neurotoxicity that can occur. There are sometimes rare instances of Parkinsonian type symptoms. They can also get the second wave of a delayed neurotoxicity that can recur. So really understanding that as well.
I think, Dr. Mansour, just going back to this slide, you hit on so many important points. We are seeing and we are hearing that Parkinsonian changes are now potential late toxicity or that can occur. Not even that late. I think they may occur after 30 to 60 days, but still,
Yeah.
relatively quick. And then now the other one that people are bringing up, and I think there was a recent study published in the New England Journal of Medicine, is secondary malignancies associated with CAR T cell um, infusion. So, and whether or not that should be a concern or at least a black box warning on the label for some of these drugs.
Yeah, and that's you bring up a good point. That's a point that's still evolving, that
Right.
I've recently discussed with a fefew colleagues, and a lot of that I'm not sure if it's necessarily from the CAR T cell infusion, but because of these patients being heavily pre-treated prior, now that the approvals are moving up, they're getting less treatment. But before that, again, this was post second, third line, even for the myeloma ones, post 4 lines of therapy, right? That they're getting this secondary MDS or something else that's evolving, and that's why many times now we have been, but ensuring that we have a bone marrow biopsy prior to really evaluate to see if there are any signs or symptoms of these secondary malignancies prior to administering CAR T cell therapy.
I think that's an important point as this therapy continues to evolve. Yeah.
Absolutely, and that's going to be part of the workup plan also prior to this, depending uh, on the actual malignancy, getting a bone marrow biopsy, a repeat PET scan, really evaluating these things prior. So briefly touch upon now there's a lot more FDA approved CAR T cell therapies, but you have it for relapsed refractory ALL, DLBCL, mantle cell lymphoma, follicular cell lymphoma, relapsed refractory multiple myeloma, and now, as of I think it was March, actually for CLL. So that's one of the newer ones as well. So as you can tell, things are really starting to not only get approved for more disease types, but also as we'll go through it in terms of the timing of the referral, starting to kind of move up towards when patients can receive the CAR T cell therapy.
Yeah, it's just exciting. Yeah.
So I think a good thing for us to touch upon is that I frequently get asked is, well, what's the timing? When should I be referring a patient for CAR T cell therapy? And again, this is evolving. So I think it's very important to have that really open communication with a specialist at a center to be able to discuss with them about the timing or see if it is appropriate to refer early on. So multiple myeloma used to be after 4 lines of therapy. Now, depending on the type, it can be either after 2 lines of therapy or as a second line or after or a third line. And so this differs. We're not using it that early yet because of the amount of different therapies that we've seen and that have recently been approved and the responses we're seeing. But again, this is why I touch upon this is it's really starting to move up. And so for multiple myeloma, if you're really starting to see them break through that first line, break through that second line of therapy, that's kind of when I would reach out and say, listen, this is a patient who's aggressively going through the different therapies. Would this be a good candidate? For DLBCL, so again, refractory disease or early relapse within 12 months of their first line of therapy. So if you get a PET scan after 3 cycles, really see that they haven't had much of a response, are concerned that they are going to be refractory or primary refractory, that's actually when I would start reaching out to them. Continue with the therapy, but get them linked up with a CAR T cell specialist. Even right before that follow-up PET scan after, just so that you have them linked in with them. And then, of course, relapse disease down the line. If they've gotten therapy, had duration failed second line therapy, they can also receive CAR T cell therapy down the line. And then follicular lymphoma. So for third line therapy and plus. So the importance of early referrals among all of these is just something that I wanted to stress upon.
Yeah. I mean, it seems like the underlying feeling for cellular therapy, such as CAR T cells, that the earlier you uh, provide it, the potential longer duration of therapy, a longer duration of response the individual may sustain, and that leads to a better sort of long-term outcome, right?
Absolutely. And again, I think just the communication is so important and really getting them seen early and even when referring out to these centers is making sure they know that this needs to be seen by someone for CAR T cell therapy. So including that even in the referral and saying we want this patient evaluated for that, I think is also something that
Yeah.
would be beneficial.
I've had interactions with colleagues after patients are initially diagnosed and then started on systemic therapy for, mantle cell lymphoma, follicular lymphoma, and even with frontline therapy, the recommendation I will be given by the CAR T cell specialist is to perhaps reduce the amount of myelosuppressive or lympho therapy. For example, if initiating bendamustine for the management of follicular lymphoma or um, uh, a non-p53 mutated mantle cell lymphoma, I've been informed, use a lower dose of some of the early, of some of the myelosuppressive therapy, because then patients are a better chance of having better collection, and they tend to do better if they go through CAR T cell therapy subsequently. Is that something
Absolutely. And
that
so,
is that
yeah,
something
when
that
you
you've
alluded,
noticed? And
yeah, when you alluded to that before, about, well, how many of these patients collect, what's the percentage? What we have found, just kind of as you briefly mentioned, is patients, for example, who have received a lot of bendamustine therapy, it's been a lot more difficult to collect. So we're telling patients, even as bridging therapy, for example, to avoid that as part of the bridging therapy, or to avoid that right before they may collect as well, and not to give as many cycles of it. So, as a part of that therapy discussion, again, I think it's also really important to have that open communication, to be able to be on the same team to decide what the best appropriate therapy would be.
yeah, yeah,
So,
thank you.
again, just for completion's sake, ALL again approved as early as second line, but we commonly use it when you don't see a quick response to second line therapy, or even an MRD positive disease, as a bridge to allogeneic transplant. So for ALL patients, many times we'll actually be using it as a bridge, and that may change with some of the newer therapies, but that is an option. Kind of, again, as you mentioned, with mantle cell lymphoma. So now with the triangle regimen, and the use of cytarabine and BTK inhibitors together early on, we're actually steering away from using autologous stem cell transplants as consolidation, just waiting then for that period where they may relapse, and using CAR T cell therapy instead. So that's something that's been evolving in the last year as well. And then with CLL, with that recent approval as well, so at least two previous treatments, including BTK inhibitor and BCL2 inhibitor, but that is new as of this year. So as you can tell, this is something that's going to continue. I think there's going to be more approvals for different diseases, and the ones that already are approved, I think, are going to start to again move earlier on. So understanding that timing, I think, is very important. So one of the acronyms that some of the societies have come together to design is called recur. So this is something that's pretty easy to remember, and something to think about. Um, this was done for large B cell lymphoma, but I think actually, from reviewing it, applies to all of the diseases we just talked about. And so think about relapsed refractory disease. You know, age and comorbidities, right? That's something we talked about early on, just to take that into to factor. One thing we didn't discuss yet, and there's actually a second part to this video that I think is really important, that talks about caregiver support and other resources for patients, but understanding that they have those, and what's available to them, the urgency of the consult, the timing, the communication, and then again, having the patients go back to their primary oncologist, and having that team like atmosphere between the community oncologist and the CAR T cell specialist. So I think this is a good point to also, you've brought up a lot of great questions, concerns, and thoughts, but wanted to get some more of your thoughts on what you thought were feelings around the treatments, barriers, things like that.
Yeah, I mean, I think that this is it's a relatively new therapy, but it's been around for now several years, and I think that, you know, I think this is a treatment for which, especially for diffuse large B cell, we're seeing sustained responses, sustained complete responses, and what appear to be cures in patients with relapsed disease, um, and that's very exciting. I think that CAR T cell therapy, um, it's somewhat disease related, like in terms of what I think a lot of people think of it. I think what we've seen so far as the role of CAR T cell therapy in myeloma, for example, after fourth line, as a fourth line or after 4 lines of therapy, is that patients typically, on average, have about a 1 year, you know, progression-free survival before the disease shows some signs of relapse, and there aren't any typically long-term cures or remissions in those patients. But I think what's interesting is as we're seeing this drug move forward in the earlier lines, I think it perhaps creates greater um, optimism, and so I think that's helpful. I think some of the challenges in the community, however, revolve around how the whole process works, which you talked about. you know, um, Setting up the collection, followed by the bridging therapy, followed by then, getting them set up for um, treatment before the CAR T cell therapy, and then that whole process of being admitted to the hospital and monitored. Uh, and now you're saying, things are changing, and perhaps these patients can even be evaluated or monitored as an outpatient rather than an
Yeah, outpatient
inpatient.
is now again, there's a good amount of patients who actually do the majority of it as an outpatient only, which is something
And
that
I think that's
is always.
relatively new. Like, for example, I wasn't aware of that's something that, has really been transitioning more to an outpatient therapy. I know that, for example, autologous stem cell transplantations in various diseases, largely that's transitioned to outpatient, but certainly patients typically have to be close to the facility where they were treated. So they're often kind of going back and forth closely and being monitored closely. I imagine that that's the same protocol for patients who are being managed with CAR T cell therapy as an outpatient, right?
Yeah, they'll still be either depending on the institution, they'll either be somewhere that housing is provided at the institution or set up somewhere very close to it where they're coming back daily. They're very closely monitored, but again, they're not in an inpatient hospital bed, for weeks at a time.
I mean, I think all of that I think, it's part of the problem in regards to what the community perspective is that some of these issues related to CAR T cell therapy are rapidly evolving. In other words, it's not a cemented therapy, like at this point, this is when you do it, right? Like, it's changing when to give it, how it's being given. All of these things are evolving for the better. But certainly, these are areas where I think, people in the community who practice like I do, we need to continue to be educated about these changes, and have some of the myths associated with therapy, as you mentioned. I think initially, one of the serious things that I would always tell my patients in regards to, whenever I refer them for CAR T cell evaluation was, we want to make sure that you have to be monitored for cytokine release syndrome
Mm-hmm.
monitoring. We want to make sure that you're monitored for neurological issues, and you're typically in the hospital for a period of time, and I think now we realize that we can kind of sidestep some of those side effects a little bit more easily with therapies. So we understand them better, we can manage them better. So I think a lot of these things are just areas where people in the community need to just continue to be educated about um, when to give it or when to be referred. It seems like earlier the better. How it's being given, which you outlined nicely, and I think some of the other barriers are just, that are probably come from the patient and not so much the oncologist. And that is, these are patients who are closely treated by their community oncologist, and then they're being told to go and see someone else, and they're going to see that other person, and then they have to forge a very close relationship with that individual, with that doctor and that care team, because they're going to go through this pretty momentous process. One thing I was just thinking of, and that is, if CAR T cell therapy is a strong potential likelihood in someone's treatment, I think the earlier you send them, the better, because then even if they don't need treatment right away, they get to know the team over at the institution. They get to understand how that therapy is provided. They can ask lots of questions well before they need to really kind of make the decision as to whether or not they're going to go through with it or not.
Sure, absolutely. And you touched upon a lot of the different barriers and concerns that I've heard from other oncologists as well. And even to add to that, some more kind of that I'd heard were some of the practice dynamics, which you kind of just mentioned is, they're with one oncologist and then, they're expected to go and right away then go see another one and proceed really
Yeah.
rapidly on a new therapy. So that's one of them. Communication, kind of like what you just described as well, as seeing them early, communicating with them, and having that open dialogue between all of the different parties. I don't know if locations of centers, if you found that to be an issue at all.
Yeah, absolutely. I mean, I think especially for patients for whom they need to relocate their families, if they need to relocate with them, if as you mentioned, they are going to be staying at local housing near the institution. All of that is an inconvenience for the individual. Just to provide an anecdotal example, and I have a patient for whom I have been trying to refer for CAR T cell therapy for myeloma, and even bispecific therapy, because we do not do induction or ramp up therapy in my uh, local hospitals just yet. This individual was telling me how it would be too difficult for him to leave his wife, for which he is the primary caregiver. So,
Yeah,
I think location, just being away from home, as much as anything else, can be a barrier for some people, depending on, who they're taking care of, what their other responsibilities are.
absolutely. I've heard insurance depending on the type. So I think getting I think that's a part where getting linked up early on, kind of as you mentioned, is important so that that can be addressed. And then I think we've touched upon some other ones as well. Um, so we kind of briefly discussed this, and I'll go back to it. But again, the reason why we keep emphasizing the importance of early referrals, communication, and timing is because bridging therapy does play a big part, right? We were talking about different therapies to potentially avoid, and then also the timing of when those therapies should be given. So that discussion between all the parties is very important. Also, patients may have chemo-refractory disease, and instead of continuing to give them chemotherapy, that may lead to worsening. Well, that may lead to infection, that may lead to worsening performance status, that may lead to a whole another series of adverse effects. When we see they have chemo-refractory disease, there may be a potential role for radiation as a bridging therapy, or they may be able to, depending on the timing or the slot availability, get into CAR T cell very quickly, get that collection process done, and then depending on the product and the disease type, have reinfusion within weeks. Again, some of them may be months, and that's where the other discussion of different therapies come into play. But again, it's important to really explore that early on. Uh, just as kind of we're wrapping up, again, just really going back to thoughts on an easy explanation, because you alluded to this, is they have this wonderful relationship with their primary oncologist, and then they're they're then sent to another specialist to you know to discuss the CAR T cell therapy more, and then some of these things go very quickly. We see them, and within a couple of days to a week, we're sending them to the apheresis center, collecting the T cells. So getting some of that information from their primary oncologist, who they trust and respect, is always also very helpful. So even to just mention to them quickly, it's a process where they collect the T cells, manufacture and manipulate them, and then reinfuse them. Just giving them that idea of it, I think, is really helpful as well. And then contact. Just the last thing is directly reaching out to the specialist, or speaking to them directly is very important. I think on the referrals, saying that we want them evaluated for CAR T cell therapy, not just as a second or third line for lymphoma, or as X line for this other disease, but specifying this will help them get to the right place. Peer-to-peer contact will really help avoid delay in care, as well as ensure a smooth transition, not only before but post. It's also the responsibility of the CAR T cell specialist to really reach back out to that referring physician, touch base upon all the things, and ensure that smooth transition for the care of the patient.
Yeah, I mean, I think what you've just touched on in terms of communication is really critical. And, in my practice, and I'm sure in every medical oncologist practice, when you're referring a patient for any type of intervention, but particularly one like this, I kind of associate CAR T cell therapy somewhat to referring a patient for a stem cell transplant. There's a lot of education that needs to occur, and a lot of communication with the with the referring doctor, or the CAR T cell specialist, or whoever, or the BMT/CAR T cell specialist. I think one of the challenges I've had is that, I refer patients, and I really value and emphasize and prioritize communication, but sometimes that's lost upon institutions, because patients get referred and then they kind of get sucked into the manner in which that institution operates, and the referring physician kind of gets left out a little bit.
Yeah,
And so that I think is probably a barrier that that perhaps not a lot of people might out may say outright, but certainly one that I think is true. And again, it requires good communication on all sides. And so, I think it's important to really find a center, a team of people that you work well with. And by the same token, I think that's important or critical from the CAR T cell specialist, that they need to communicate well with their referring doctors, so that the patient is well taken care of.
yeah, absolutely. I completely agree. Um, uh, some of the other diseases that are now really having some clinical trials and taking place, I briefly listed there. Kind of the whole point of this was just to say this is evolving. There's going to be more diseases that are being treated with this type of cell therapy. So again, forming this relationship, and taking the time to understand also the treatment itself is really important. And then as we're wrapping up, I just wanted to briefly mention that I know there are some additional resources also, with actually a second video that alludes to some other resources, both for physician and for the patient. Some of the general CAR T patient education with let's chat CAR-T.com. There's also, again, a video, a second part for patient resources by LLS, the CAR T webinar as well. that I think patients and physicians will find really beneficial. So I urge you all to also watch that.
Well, listen, I think we discussed a lot, and I think that CAR T cell therapy, from what we're hearing from you, and certainly just in the and out there and in the literature, and is that it's a treatment that's here to stay, and it looks like it's moving up into earlier lines of therapy, and will have a greater role. So we certainly have to become more comfortable with it, and that was really our goal with this discussion today, to try to become more comfortable with CAR T cell therapy. So, um, on behalf of MOASC, Dr. Mansour, I really wanted to thank you for joining us, and we appreciate you listening to this discussion. Thank you, everyone. Good night.
My pleasure. Good talking to you.
Likewise, take care.